Guys, we're going to start talking about the benign biliary disease now. Two sections. There's first we're going to talk about calculus, and then we'll go to the acalculous biliary diseases. First, some background on the stones themselves. So 80% of stones, 80% of those stones are cholesterol in nature. That means 20% are not. Of the 20%, there's two groups of the pigmented stones. The first are the black stones that are found most often in the gallbladder itself. They tend to be more associated with hemolytic conditions and cirrhotics. Then there's brown stones. Brown stones are more often found in the bile ducts. They're more indicative of a biliary dysmotility and are more susceptible to bacterial infections. So why exactly do pigmented stones form? There's really four reasons here. We'll go through each one in kind. First, there's a supersaturation of the bile sent into the gallbladder. So the bile, when it comes out of the liver, is very much in a state of motion, and that is much easier for solids to remain suspended in that. And then as soon as they get into the gallbladder, stasis ensues, and so those precipitate out. Second is a concentration of the bile within the gallbladder. So obviously the bile, when it enters the gallbladder, is of its, of the concentration that it was produced, but then as it sits there in the gallbladder, salt is reabsorbed out of the wall, or salt is actually actively removed out of the wall, and as it does so, it brings water along with it. That leads to hypersaturation or hyperconcentration of that bile within the gallbladder. Next, there's a phenomenon, crystal nucleation. This is where glycoproteins and immunoglobulins essentially act as a catalyst for formation of these gallstones. And then there's the fourth contributing factor, which is the gallbladder dysmotility, and this is in prolonged fasting states, such as those listed there, and when someone's on a long-term somatostatin analog. This leads to essentially just a disuse of the gallbladder, and as the bile sits there, it tends to precipitate out in stones. One point of terminology I want to make sure we clarify right off the bat is biliary colic, and so this is essentially when stones are intermittently obstructing the cystic duct. CCK, natural or artificial, both induces the gallbladder contraction against that lodged stone. That's what causes the pain. When someone has symptomatic cholelithiasis, so the question obviously presents itself, what to do? Should we do anything? Most gallstones are asymptomatic, and most people with gallstone or symptomatic cholelithiasis are indeed most patients that have cholelithiasis are indeed asymptomatic. Of those with gallstones, so of all those with gallstones, not just those who are symptomatic, but of all those patients who have gallstones, only 20 to 30% will have symptoms within 20 years. Of all those with gallstones, in fact, only 1% will have a complication without first getting cholecystitis. So, so generally speaking, we advise not to take out the gallbladders just because there are stones within the gallbladder. That said, there are exceptions. So those that have a high rate of pigment stone formation, such as Crohn's patients, those were when cholecyst, and also with patients that have hemolytic conditions. When a second condition would be when cholecystitis can prompt a crisis, so in patients that are immunocompromised or are otherwise vulnerable. When there's a calcified gallbladder wall, just to see if everybody remembers what that's called, porcelain gallbladder. When somebody has a large gallstone greater than 2.5 centimeters. When there's a long common channel that contributes significantly to the risk of gallstone pancreatitis. And when somebody is undergoing bariatric surgery, number one, the rapid weight loss leads to a greater likelihood of symptomatic cholelithiasis in those who have cholelithiasis prior to their surgeries. And then ERCP is much more difficult, especially as we know after a Roux-en-Y procedure, it's very difficult to access that, and so it must be done now. And then finally, in transplant recipients, and again, this kind of harkens back to that immunocompromised status that we talked about earlier when cholecystitis can prompt a crisis. Among transplant recipients, it's always advisable to take gallbladder out. So there are some medical treatment options that we do not use very often, but among them, first of all, they're not utilized heavily because they have a high failure rate, but among them are oral bile salt therapy. The second is contact dissolution, which is essentially injecting a solution in that will dissolve the gallstones, and then you can essentially aspirate that solution. A third would be extracorporeal lithotripsy, so essentially a shockwave therapy, and this can be done, and it is actually done at some centers. At least one center in Michigan that I'm familiar with, but it's only done for single stones up to 2 centimeters. So when you get a radiology read about a gallbladder, they'll address stones, polyps, hepatic parenchymal disease normally, the wall thickness, duct diameters, the existence of sludge, pericholecystic fluid, and also fat stranding associated with that. And then this phenomenon occasionally cholesterolosis, which is when the mucosal macrophages take up a lot of that cholesterol and it gets up to the wall. So this is an image of cholesterolosis here. This as well here, and then this as well. It's a pretty picture. This is for Leslie. All right, so while we're talking about radiology, let's talk about some of the tests that we use for that. So first, back up even before we get to radiology, the physical examination. If somebody's tender in the right upper quadrant, the sensitivity for that being gallbladder disease in someone that does not have a gallbladder is 58%, but the specificity is only 42%. If it's a Murphy sign, which is a pain with inspiration, essentially arrest of inspiration with palpation under the liver during inspiration, that's a sensitivity is 48%, but it's much more specific finding. As far as imaging is concerned, for someone, almost never would anybody have an acute abdominal series ordered for gallstones, but let's say they do happen to have an acute abdominal series ordered for them. This is again not for cholecystitis. This is what that asterisk is for, but for cholelithiasis themselves. The sense if they show up on a acute abdominal series, it's a tremendously specific test because if they show up, well, they must be there. CT abdomen pelvis and CT chest, because as you know, CT chest oftentimes or most often include at least the gallbladder on the caudal aspect of their imaging. Sensitivity 65%, specificity 90%, so pretty high specificity there. And then right upper quadrant ultrasound, which is oftentimes the test of choice, is both very sensitive and specific for gallstones. And then MRI is the most specific and sensitive, with the exception of a HIDA. Okay, so getting an MRI, MRCP is very sensitive and specific, but of course getting a HIDA is even more so, especially for cholecystitis. So let's start talking with our conversation here. Let's transition towards acute cholecystitis itself. So that we just talked about biliary colic, which is where a stone or sludge blocks the cystic duct. Acute cholecystitis is also where a stone or sludge blocks the cystic duct. So the difference is here. This is biliary colic is temporary and self-limited, and as soon as the gallbladder relaxes, that stone falls back out of the cystic duct. In acute cholecystitis, this does not resolve spontaneously, and there tends to be this cascade here where you, well, I guess this multifactorial picture where you get tissue inflammation, you get wall edema, infection of stagnant bile, which is a secondary process. It's important to note that the bile only becomes infected because it's there. It's not the primary cause of acute cholecystitis. Then there's a subcervical hemorrhage that occurs as well. So with an unresolved cystic duct obstruction, that leads to the infection of bile, like we just said. That's the secondary process. That leads to distension and wall ischemia, ultimately necrosis, gangrene, and emphysema. The goal is to catch it somewhere along the line before it gets all the way to the emphysematous gallbladder. Acute cholecystitis occasionally is often operated on right at the time of presentation, but there is some indication for an interval cholecystectomy. In these patients who have a severe presentation or have some pancreatitis or other conditions we're going to talk about later, we might do an interval cholecystectomy. This would be, you make these patients NPO, give them IV fluids, IV antibiotics, and the evidence actually shows that if you perform this cholecystectomy within the first week or that 6th week, there's actually the risk is the same. The reason I pick 1 and 6 is because 2, 3, 4, and 5th week, those weeks are actually a higher risk of complications if you're proceeding with a laparoscopic cholecystectomy. So the ideal timing is either in that 1st week or in the 6th week. Medical management, even with antibiotics and whatnot, does fail in 20% of patients, meaning you still have to take them back for gallbladder not on your intended time frame. Okay, there are difficult gallbladders. The principles here are when you have a difficult gallbladder, it's early convert to open. It's okay to perform a partial cholecystectomy, although it's rarely done nowadays. You can also, if you anticipate this ahead of time and the patient is particularly comorbid, you can do a percutaneous cholecystostomy tube. Then 3 to 6 months later, you oftentimes will throw some gastrografin up and through that tube and flush it in to determine the patency of the cystic duct. If it's patent, then you can pull the tube out, and oftentimes take that patient back to do a scheduled gallbladder at that time, or perhaps in some cases not. Chronic cholecystitis, so we're transitioning from acute to chronic cholecystitis, This is where someone has repeat episodes of biliary colic. It leads to fibrosis of the gallbladder neck. So stones are getting beaten up inside that neck over and over again. It leads to fibrosis there. Only 50% actually endorse this postprandial pain after a fatty meal. So we ask that of all our patients, but only 50% will actually have that history. Again, to go back to kind of biliary colic here, so it tends to be epigastric and right upper quadrant pain that radiates around to the scapula. It does not normally penetrate through the body. That would be more suggestive of pancreatitis picture. It's often associated with bloating, nausea, vomiting, and it waxes and wanes. So that's the colicky nature. It all may occur without actual stones, and it's important to put that there, that even if the patient does not have stones documented on imaging, that they may have a picture very similar to this and may in fact be consistent with that. So if someone has chronic cholecystitis and they present to your outpatient office, if they have mild symptoms, they actually have a fairly low risk of annual complication. Again, as you can see here, 1 to 3%. And so it may be worth discussing lifestyle and dietary modifications. Most interventions that we do in general surgery, it seems, or we suggest lifestyle dietary modifications do in fact not work due to patient discipline, but in some patients it may be sufficient to get the job done so that they can not have to have their gallbladder taken out. If the patient does, however, have severe symptoms, then there's a 7 to 9% annual complication rate from not doing the cholecystectomy, and thus it makes sense to actually do that procedure on the patient in most cases, unless they're very near the end of their life. Symptomatic cholelithiasis is indeed an indication for cholecystectomy. So just kind of in sum, if someone does have symptomatic cholelithiasis, they should get a cholecystectomy, or at least in the appropriate patient, that is an indication in itself. That said, you need to document this, okay? So you have to document the chronicity of the pain and other symptoms, as well as the radiologic evidence of the stones. That's essentially the way that you can justify doing a cholecystectomy in these chronic cholecystitis patients. Now, if you encounter while you're waiting to do or you have a chronic cholecystitis patient and you're going to schedule them for an outpatient procedure or whatnot, it's okay to do so, of course, and that's the standard. But if they do have pain that lasts over 24 hours, fever, a significant leukocytosis, or just something triggering your gestalt, just slide down to the OR and don't wait on it. And as we talk about later, you want to make sure that you don't get back yourself into a corner with something like cholangitis. All right, so we're going to transition next to choledocholithiasis, and this is when a stone lodges within the common bile duct or at the ampulla. It's classified as either a primary or a secondary choledocholithiasis. So these choledocholithiasis, if they're primary, they form organically in the common bile duct 2 years, some say 1 year, but anyway, a couple years after cholecystectomy. Normally a brown stone, as you remember back to the beginning of the top of the lecture here, that brown stones are more likely to form in the duct themselves, more common around Asians, and there's a higher infection risk. I've underlined some of the more important things throughout the entire presentation, and frankly, I think all my presentations that are important to maybe more important key points are the underlying. So when you have primary choledocholithiasis, the bacteria that are trapped in there secrete enzymes, glucuronidases are among them. What this does is this actually hydrolyzes this bilirubin and the glucuronide bond. So that's a natural bond. It actually hydrolyzes that bond. Now the bilirubin precipitates and binds up to cholesterol, and that essentially forms those stones, the primary stones. Now as you transition to secondary stones here, secondary stones, somewhat maybe counterintuitively, are formed within the first 2 years of a lap chole. Again, 1 to 2 years, but probably if you just one number to remember, less than 2 years after lap chole. They represent the vast majority of all common bile duct stones in the U.S. 10% of lap choles will actually leave a stone. Obviously, most of them pass ultimately, but in some cases they don't, and that becomes a secondary choledocholithiasis. And 1 to 2% are clinically relevant. So again, 10% of lap choles leave a stone, but only 1 to 2% become clinically relevant. Symptoms of choledocholithiasis are similar to acute cholecystitis, in which you get biliary colic and but instead of biliary, this is where the distinction begins, is with jaundice and scleroicterus. So now you're getting obstruction not at the gallstone or gallbladder itself, but downstream from the gallbladder. And as a result of that, you get back up into the liver and potentially pancreas as well. So you get scleroicterus, jaundice, dark urine, light-colored stools, and diarrhea. You also have notably an elevated direct bilirubinemia relative to the total bilirubin, and that ratio is significantly elevated. Oftentimes you have elevated ALK phos, AST, and ALT as well, indicative of the backup into the liver. And the common bile duct is dilated over 8 millimeters. If you have a low suspicion, so you have a patient that presents that has acute cholecystitis, and you have a low suspicion for choledocholithiasis, the MRCP is the appropriate test. Again, we talked about that earlier. For sensitivity, 92%, specificity, 97%, both for acute cholecystitis as well as for common bile duct stone. However, if you do have a high suspicion, this is not what we do at Mount Carmel, but if you do have a highest suspicion, the literature suggests you ought to go right to ERCP, which is both diagnostic and curative. Now, the treatment of choledocholithiasis is there's multiple options. One is ERCP, second is a laparoscopic common bile duct exploration, and third is an open common bile duct exploration. If you perform an ERCP, 75% are successful that first time. I feel like we probably have a higher rate of that here than 75%, but that is the published rate. 90% are successful with repeated attempts on separate days. There's an 8% complication rate among patients that undergo a sphincterotomy in a sweep. Oftentimes this is pancreatitis. If cholecystectomy is not performed in these patients, 50% of patients will reobstruct. So again, if you use an ERCP to clear a stone, 50% of those patients will reobstruct. Now, interestingly, if the patient is over 70 years old, only 15% will reobstruct before the end of their life. So there's certainly some wiggle room if you don't think the patient is optimized surgical candidate. Then perhaps, and they're over 70, then you can certainly justify not undergoing a cholecystectomy in those patients. A laparoscopic common bile duct exploration, we talk about this recently because it does require indeed a good facile surgeon and one who's experienced in this procedure. You can do two approaches. One is a transcystic approach, which is normally favored, and that's essentially coming down the bile duct itself, or the cystic duct itself. Then there's, but if the stone is too large, or there's a friable duct, or there's too many stones, then you have to essentially perform an incision along the common bile duct and extract the stone itself. So there's the transcystic approach, which again is to go down, essentially cannulate through the duct, and then there's the extraction incision approach, which is favored in those conditions as we just discussed. Now, open common bile duct exploration does have a fairly high morbidity and mortality relative to most procedures that we perform. 12%, let's say on the top end, morbidity, and 2% mortality. So if you're unable to clear an ampullary stone, and this does occasionally happen, if you simply cannot clear the stone out of that ampulla, you can still complete the case. You just have to do a much more complex case, which is essentially to create a biliary enteric anastomosis. Two options for that are choledoco duodenostomy, so you're bringing up a loop of duodenum. The benefit of this is that you can still perform an ERCP. Unfortunately, it drains poorly. And there's this risk of sump syndrome, which is essentially that the bile ducts, well, just as we described, they empty poorly, and that can cause certainly symptoms down the road. The other option, instead of hooking the biliary ducts up to the duodenum, you can do it up to a jejunostomy, or to the jejunum. So that's called a choledoco jejunostomy, and this is normally performed, or really can only be performed in a Roux-en-Y fashion. Unfortunately, here you cannot perform an ERCP down the line. The good thing about this, however, is that you don't have issues with draining, and so sump syndrome is no longer a concern. There's a phenomenon of Meritzi syndrome, and this is when a gallstone lodges in the cystic duct, as in this picture right here. It obstructs the common bile duct to some degree, and the degree to which it obstructs that common bile duct is the rating scheme or is the classification scheme that we're just going to talk about in a minute here. Symptoms are obviously going to be jaundice and pain. There's going to be pain because there's obstruction, and there's going to be jaundice because there's obstruction. Diagnosis is often performed with the ERCP, and treatment can also be via ERCP or operatively. So type 1 Meritzi syndrome is when you have compression of this is the gallbladder on the left, and of course, as you can tell, the biliary ducts on the right. So this is where there's external compression on the common bile duct, but there doesn't happen to be narrowing of the lumen itself. That's generally considered to be underdiagnosed. For this, if you encounter that, you perform a total or partial cholecystectomy. Normally, a total cholecystectomy is fine. and the common bile duct exploration is not required in this. The second type 2 Mauritzes is when compression causes common bile duct lumen narrowing. So now it's starting to press into that common bile duct, and instead of pressing in a gentle and non-deforming way, now it is indeed deforming the lumen. You treat this with a cholecystectomy and then closure of the defect itself, because now since the gallbladder, the reason this occurs is because the gallbladder is sort of starting to erode into the common bile duct, and so you normally it leaves a slightly larger defect, and you can close it either with a slow absorbing suture, or you can place a T-tube, or do a choledocoplasty, in which you leave a remnant of the gallbladder and actually use that as a patch over the defect in the common bile duct. Now, a type 3 Mauritzes is where compression causes common bile duct necrosis. This is where, again, it's just like we talked about 2, but the problem here is that now there's necrosis of that common bile duct itself. So the tissue of the common bile duct, even after you take the gallbladder out, is certainly compromised. Treatments here include, again, the choledocoplasty that we just described, where you leave part of the cystic duct, and or the gallbladder itself, and you can form a patch out of it. Then there's far more invasive option, which is the bilioenteric anastomosis. This is what the procedures we just talked about earlier, where you do a choledochoduodenostomy or a choledochojejunostomy. And again, the choledochojejunostomy is generally favored. Type 4 is where you actually get a fistula. So now you've got such a significant erosion that now there's essentially it's one continuity. It's more or less a diverticula, you might think, off the common bile duct. It's the cholecystocholedochal fistula. In this case, you really do have to do the biliary anastomosis, bilioenteric anastomosis, and again, the choledochojejunostomy here is preferred. And then type 5, this is sort of less formal classification, or type, but type 5 is when you have any Mauritzes syndrome, and then on the back end you've got a cholecystoenteric fistula. So this is where you're kind of eroding at both ends of the gallbladder. If this is the case, then you treat it more or less like a gallstone ileus. We're going to talk about that in just a second. But then you also have to bring up a choledochojejunostomy. So if there is, so in this case, when you have the erosion like gallstone ileus, you have erosion of the back of the gallbladder or any part of the gallbladder into the intestine, normally the duodenum. Then you do an enterotomy to remove the stone if a stone has passed through. Often the stone lodges down at the ileocecal valve, and so you make a transverse incision proximal to that, back the stone up, pull it out that incision, and then you repair that enterotomy. And then in a healthy patient, you do the cholecystectomy now, but if it's a comorbid patient, it's actually okay to do it later or potentially never. This is essentially blending both that type 5 Mauritzes with the gallstone ileus. So let's talk about, kind of narrow down to the gallstone ileus in particular. That's when the gallbladder fistulizes to a duodenum normally, like we just talked about. The gallstone passes through, it mechanically blocks, so it floats just drifts all the way down the small bowel and gets stuck. Not actually at the ileocecal valve. Most people think it gets stuck there. It's not actually at the ileocecal valve, but actually proximal to that, where there's a narrowing of the small bowel into the cecum. Occurs more often in elderly patients, because they're more likely to have a necrotic gallbladder. And the CT will demonstrate pneumobilia and small bowel small bowel obstruction with pneumobilia. And then, as we just discussed, but here in a slightly greater detail, to address this, you perform an anti-mesenteric longitudinal incision, just proximal, so just upstream of the obstruction. You back that stone up and out the incision, and then you if there's, you inspect the area and the tissue there. If at that narrowing there happens to be pressure ischemia, let's say from that stone being lodged there and being a lot of backup of gas and obstruction behind it, it's causing a lot of pressure there. And if it's compromised the intestine at that narrowing in any way, then you obviously resect that. And then you actually run the bowel afterwards. So when you run the bowel, 10% of the time you'll encounter more stones proximally. And now, if it's a healthy patient, just like before, you repair the enterotomy and you perform a cholecystectomy now. And if it's a comorbid patient, you either repair the enterotomy and do the cholecystectomy either later or never, depending on how comorbid the patient is. Moving along to other gallstone-associated diagnoses. So spilled stones, this is something we all encounter occasionally. Risk factors for it are essentially stones that are, make sure the definition's out there. This is when stones come out of the gallbladder during a cholecystectomy. So the risk factors are active or acute cholecystitis, pigmented stones, more than 15 stones, a resident performing the procedure. These are all literature based. And then, these can lead, normally we sort of suck out what we can and call it good. These can lead to chronic abscesses in Morrison's pouch, small bowel obstructions, and ultimately to fistulas, oftentimes, in fact, atmospheric fistulas. So the key is prevention. Try to find them, do lots of irrigation, and then post-op antibiotics if you spill a lot and you're not able to. Next, you could have disorder that is associated with gallstones is a gallstone pancreatitis. This is so normally when you have a pancreatitis of unknown cause, first make sure you get ultrasound and determine if it's gallstones. Statistically, 50% of the time it will be gallstones in a patient without other cause. If the gallstone is the proximate cause, pancreatitis is usually self-limited. So the pancreatitis is a much milder version and that doesn't become fulminant pancreatitis. ERCP is indicated to remove the stone. They can place, they'll almost always do a sphincterotomy. They can place a stent, but oftentimes a stent's not required because that's not really the problem here. So there's not a stricture and whatnot. So normally they don't need the stent, but a sphincterotomy is normally performed. And a cholecystectomy is performed then once the patient recuperates from a pancreatitis. So just as a kind of a reminder to back up what's normal as we lead into our next topic, cholecystitis, you get right upper quadrant pain, positive Murphy sign, you get those elevations like we talked about as well as in the white cell count, and you get fever. Choledocholitis, you get right upper quadrant pain Murphys, but now you get that elevated direct bilirubin to total bilirubin ratio and an elevated, or I guess we'll say the direct bilirubin becomes a greater and greater composition of the total bilirubin, component of the total bilirubin, and then there's elevated LFTs, and you start to get jaundice and scleroicterus here with choledocholithiasis, okay? Now, note neither of these causes overt sepsis, rigors, hypotension, altered mental status, okay? So if you find these, this may be triggering a memory in your mind, Charcot's triad. These are Charcot's triad is jaundice, right upper quadrant pain, and fever, okay? And then Reynolds pentad adds hypotension, altered mental status. Now, notably, among Charcot's triad, so they're in the blue, jaundice, right upper quadrant pain, and fever, jaundice is only seen in less than 50%. I think it's like 46% of patients. And so a lot of patients have fever and right upper quadrant pain. That seems pretty very common. And so it's difficult to distinguish these, but certainly an elevating fever and a more sickly looking patient would suggest that you're heading towards ascending cholangitis, which is a bacteria up into the biliary tree. Two absolute factors for this are bacterbiliary, bacterbilia, so normally Klebsiella, E. coli, Enterobacter, Pseudomonas, and Citrobacter. In order, those are the most common agents. And then there's the obstruction to flow that's required, and that's almost always going to be a stone in the context of ascending cholangitis. A right upper quadrant ultrasound will reveal a dilated biliary tree, again greater than 7 or 8 millimeters, and at the common bile duct, and then just a dilated biliary tree as you go up. You can do ERCP, PTC, or endoscopy to perform a cholangiography to perform this diagnosis if need be. And then to remove the stone in ERCP or endoscopy, normally it's done ERCP wise, but it can be done endoscopically. And then to decompress the biliary tree, again, normally with removal of stone, decompression is performed as you remove the stone. Let's say you're unable to remove the stone, you can place a T-tube, or you can do percutaneous decompression. All right, so now we're all done with the calculus biliary diseases. That was a whirlwind through it. So now we're going to move on to the acalculous biliary diseases briefly. So we'll start with, acalculous cholecystitis. This is essentially an acute cholecystitis presentation. Generally tends to have a more fulminant presentation, and almost always seems to appear in the same sort of patients. And it's an elderly, intubated patient who's on long-term, inpatient therapy and ICU stays. And they have multiple comorbidities. This is the sort of patient that oftentimes does have acalculous cholecystitis. They'll have right upper quadrant pain. HIDA is very useful, although there is a significant false positive rate with HIDAs. Okay, in this context. Treatment would be an open chole versus a perc chole. Generally speaking, you don't do laparoscopic cholecystectomies on these patients because they are they can't tolerate it, but they're normally open or percutaneous or open procedure if you want to perform the procedure at all. If you don't want to, a percutaneous cholecystostomy tube is always an appropriate choice in these patients. The sphincter of Oddi dysfunction. This is the somewhat questionable diagnosis in the literature, but it is pain, elevated LFTs, and occasionally pancreatitis, especially if someone has a common channel, a long common channel. And the common bile duct here in this case is actually oftentimes dilated up to 12 millimeters. There's a endoscopic manometry that can be used, which from my understanding is rarely used. But if you perform a sphincterotomy, this does resolve the pain a lot of the time. This is, we probably have, there's things like morphine can constrict that sphincter of Oddi and whatnot. That's another facet to this particular pathology. All right, so if you do, moving along now, if you encounter an iatrogenic bile duct injury, the key is to control the infection. So make sure the patient has IV antibiotics and make sure there's a drain in there to drain fluid collections intraoperatively. I'm sorry, leave the drain intraoperatively, but if it's something that's discovered later, then you do a percutaneous drainage. You do need to delineate the anatomy because it's important to figure out, essentially what's leaking and where. And so to do that, an MRCP or PTC or ERCP are most useful. We can also, and we'll talk about HIDA in a second as well. So the controlling the leak is ERCP or percutaneous transhepatic drainage. So and that's oftentimes what we use here. Okay, we have one of those two. And then you have to restore the anatomy. And so to restore anatomy, you just essentially, what I mean by that is you have to restore continuity where bile can flow from the liver and into the alimentary canal. So it's currently not doing it. Obviously, it's leaking out into the abdomen. So we need to restore the continuity. So you can maybe stent if it's a small defect, or in many cases you can do a hepaticojejunostomy, which we've talked about several times. Now, there's a phenomenon called recurrent pyogenic cholangitis, which is almost exclusively a result of one of these two bugs, Clonorchis sinensis or Ascaris lumbricoides. They secrete an enzyme called glucuronidase, and again, just like we talked about before, just like other these are organisms, but just like we talked about before with those bacteria, this enzyme glucuronidase breaks down that bilirubin glucuronide to bilirubin, and bilirubin precipitates out, and it becomes essentially binds up with cholesterol and forms brown stones. You get repeat episodes of cholangitis because now these are seated stones, and it can often lead to abscesses and actually ultimately to cirrhosis in patients due to the metaplasia that's caused by recurrent inflammation cycles. So what to do? Well, right off the bat, you identify this, you give the patients antibiotics, and you remove the stones if possible. You bypass strictures if required, and you improve biliary drainage. So ultimately, it's when you see a multifaceted obstructed a patient that has many obstructed ducts that seem to be obstructed at different levels and to different degrees. Oftentimes, something like recurrent pyogenic cholangitis may be, at least ought to be on the differential. Now, notably, I did earlier say that the repeat inflammation does cause metaplasia, and so when there's metaplasia, there's risk of conversion to carcinoma, and so there's actually a high risk of cholangiocarcinoma in these patients. So if the patient has a particular lobe of their liver that is more affected than others, or let's say a lobe by itself that's infected, it ought to be resected in block. In doing so, resected in whole. And in doing so, what you're able to do is essentially remove any further seeding and any sort of risk of that infection spreading to the other less involved parts of the liver. Unfortunately, most of the time, this tends to be a more disparate disease. It doesn't involve every duct, but it'll involve many ducts in many locations throughout the liver. Now, if you do take these patients, again, let's say they have that high risk, they do have it in one lobe, and you want to prevent their risk of cholangiocarcinoma, or they're symptomatic from their strictures, you take them to the OR. They actually have great outcomes. Outcomes are actually really surprisingly good, like 93 to 96% complete resolution at 1 year. And again, if there's no cholangiocarcinoma, that's why I say bah humbug there. So assuming that there's no cholangiocarcinoma in the pathology specimen, you've done that patient a lot of good. Biliary dyskinesia is the next diagnosis we'll talk about here, and this is biliary colic, but there's actually no stones on the ultrasound. You rule out other etiologies for pain with a CT and EGD. You can order a HIDA, and the HIDA with CCK will show essentially ejection fraction less than 33% at 20 minutes. And this essentially, we would expect this the gallbladder to be contracting, and if it's not contracting well, then that's suggestive of biliary dyskinesia. And you have the same symptoms as you get with acute cholecystitis, although the radiologic presentation is different. You get a lot of inflammation and pain at the right upper quadrant. On these patients, if you do encounter one, and it seems very likely to be the diagnosis, then you ought to perform a cholecystectomy because it does resolve pain in 85% of these patients. ERCP and sphincterotomy then resolves the pain in the remainder of patients that are left. And I say that because initially, if you use the ERCP, or at least the literature, according to the literature, if you use the ERCP and sphincterotomy sphincterotomy as the initial intervention, then then instead of your success with the cholecystectomy being 85%, it's actually only about 29 to 35%. So these patients do not get an ERCP and sphincterotomy first. They ought to get a cholecystectomy, and then only if required do they need that ERCP. Now, moving towards our final topics, our primary sclerosing cholangitis. This is inflammation and scarring of the intra or extrahepatic, or both, biliary tree. It advances to cholestasis, where essentially the ducts are so blocked up that the bile that's produced sits there and is unable to evacuate or escape the liver. Or if it's in the common bile duct, leads to a situation in which you cannot, bile cannot leave the gallbladder. It's autoimmune related, radialis and ulcerative colitis. Notably, and this is a question that is encountered, there's no benefit from performing a proctocolectomy in these patients. I mean, there is certainly for their ulcerative colitis if it's indicated, but it actually has no bearing on whether or not they get this disorder or not. So this appears to be more than simply a response to inflamed colon. P-ANCA will be elevated up to 80% of patients. It mainly presents with fatigue, pruritus, and jaundice. And the one, again, just like we talked about before with the clinorchus and whatnot, when you have a significant inflammatory risk, you start to get metaplasia, cholangiocarcinoma, or you get the metaplasia and then the carcinoma sequence. So it's a risk here. On ERCP, you'll see a pattern called beading or chain of lakes, and I have a couple pictures of that coming right ahead. And then this is a very difficult disease. There's options are essentially biliary reconstruction versus liver transplant versus palliative, and it's essentially all depends on how much is involved. There's a lot of extrahepatic involvement, but very little intrahepatic involvement. Patient might be a decent candidate for biliary reconstruction, where you essentially excise out the involved area, and then you can re-anastomose those to a jejunostomy loop. But more often, I think these patients are more diffusely affected, and there's some intra-lobar and intra-parenchymal involvement. And so, if you've got essentially this sclerosing cholangitis that extends way up into the actual lobes of the liver themselves and involves the biliary tree up inside the liver, then that patient is only a candidate for transplant. And this is this is a diagram, obviously, of the kind of this periodic stricturing that may occur with the biliary or with primary sclerosing cholangitis. And here on the right is ERCP suggesting that beading or chain of lakes. Here's another one suggesting the beading or chain of lakes here. And certainly you can see periods where of dilation and contrast, and periods where there is not. And here again, you'll see this looks like maybe more like the more earlier in the cystic structure. You get a lot of involvement. Choledochal or biliary cysts are, I think, our final topic here. These are rare. They occur in Asian females. 90% have this APBJ, which is the anomalous pancreaticobiliary junction. Okay, and so what is this? This is essentially where the pancreatic and biliary pancreatic duct and biliary tree essentially fuse into a common channel too early, so the common bile duct and pancreatic duct become fused too early. The pancreatic duct is at higher pressures and refluxes kind of in episodic squirts, and so as it does this, it causes reflux of those enzymes up into the biliary tree. This causes chronic irritation and degeneration. We can identify this oftentimes with CT, and then if it is identified, it's almost always prudent to obtain an MRCP to further characterize the cyst. 10 to 30% of these will advance to cholangiocarcinoma, again because of that chronic inflammation coming from the pancreatic enzymes refluxing. Okay. The treatment is to resect the cyst. You do so in different ways. There's variable reconstruction ways that probably are outside the scope of this conversation here. But essentially, these are the various types. With each type, as the reconstruction is essentially just made, or is just a way to excise the cyst and then reapproximate normal anatomy. Another image of those same types. Next is Caroli disease. This is again rare in Asian. There's a lot of things that are rare in Asian in this lecture. 7% of these patients advance to cholangiocarcinoma. So there's two real subsets of Caroli disease. There's focal disease, which is autosomal recessive, and it's associated with polycystic kidney disease. Okay, so a single lobe is severely involved. And then there's a simple form, which is where essentially you have diffuse involvement of much of the liver. This is autosomal dominant and is also associated with polycystic kidney disease, but also with portal hypertension and hepatic fibrosis. And largely this is due just to more global, essentially as you get the cysts forming throughout the biliary tree, they apply significant pressure on the hepatic parenchyma. Since the portal system is so low in pressure, it just doesn't flow well. And then as that more and more of that occurs, essentially you start to get a inflow restriction to portal flow that causes the cirrhosis, the fibrosis, and then portal hypertension. And then gallbladder polyps. I believe this is actually in fact the final of the topics. They are very common. They can be broken down into a couple categories. So there's pseudotumors, which include the cholesterol and the adenomyomatosis variants. So cholesterol, these are cholesterol polyps. They tend to be less than a centimeter. There's lots of them throughout the gallbladder. We looked at some pictures of those earlier. Then there's adenomyomatosis, which is when you have normally a single sessile polyp, which is greater than 1 centimeter, and these are often also characterized as microcysts on radiology reads. Outside of the pseudotumors, there are more formal tumors. Of course, there's malignancies that are discussed in the other lecture, but as far as benign, there's adenomas, and these are difficult to distinguish from adenocarcinoma, but they do have no submucosal invasion. So generally speaking, the approach is to favor an open cholecystectomy to reduce the risk of perforation or seeding if indeed you are wrong and it is actually an adenocarcinoma. You excise this with a thin rim. There's actually not a formal a recommendation as to what size of rim to leave because it's essentially depends so much on where you are in the gallbladder. But it's also okay to observe. So if you have small adenomas, and you essentially the adenoma, when it becomes adenocarcinoma, is no longer slow growing. So if you have a small, slow growing thing, it's very likely an adenoma. And these would be essentially would be okay to observe normally on a 6-month interval. And and this is okay to continue doing as long as they're classified as low risk on ultrasound. So the best way to image these is to continue to follow them on a high resolution ultrasound on a 6-month basis. Okay, that brings us to the end of our lecture here. That's the end of the benign cystic lecture. Or benign biliary lecture, and we'll certainly look forward to further discussion in chief lecture.